Hi, I'm Ray Gillick. I'm a nurse for the Dublin Simon Community. I've been a nurse now for 39 years. 20 of those have been spent working in addiction medicine. I currently work in homeless services for Dublin Simon in their primary care, and before that I was working in their detox program. What a community detox is, it's actually going through a managed alcohol withdrawal in the community setting. So it's not taking place in a hospital, it's not taking place in any kind of institution. It is usually a GP prescribing medications to manage the withdrawal symptoms, and the person going through the detox should also have supports from their own support system they have, whether if it's in homeless services, they might have support workers, key workers, counseling staff who can help them during that process as well. Alcohol is actually the most damaging of all substances, even though it's the one that's most readily available. When someone is drinking on a daily basis and then suddenly stops, they will often go through withdrawal syndrome. That includes increased temperature along with sweating, feeling of anxiety and shaking side, increased tremors and shakes, nausea, vomiting, diarrhea. So there's risks. There's a risk of seizure or epileptic fit, risk of heart attack or sudden cardiac event, risks of falling, of course, because they become unsteady on their feet during the withdrawal, risk of having to be hospitalized, as we mentioned, with liver problems, pancreatic problems. Well, the physician's role is basically managing the medication, and what they do in that situation is that we replace alcohol with another chemical that stimulates GABA. We haven't improved much in 100 years. If you went through a detox 100 years ago, they would probably locked you in an institution and giving you measured decreasing amounts of alcohol. What we do now is we replace the alcohol with a benzodiazepine. This is a group of medications that include Librium that stimulate GABA, just like alcohol does. And so we then establish that medication replacing the alcohol and then slowly taper the medication. Usually someone will stay on a steady dose to about day 3 because the risk of seizure is greatest in the first 3 days. And then after that we can start tapering it down. And the reason we have to taper it, if we just suddenly stop the Librium or any kind of benzodiazepine and detox, we're not detoxing the person, we're just replacing the alcohol. They'll have severe cravings and they'll want to drink right away to take care of the withdrawals they're having from the benzodiazepine. First thing that would happen is they would actually go to their GP. Sometimes it might be good to go with a support worker so they also get the same information as to what's going on. And the first thing the GP would do is get a history of their alcohol and substance use. The reason this is important is how much medication and what medication they receive during detox is based on how much they're drinking, how long they've been drinking. What determines severity of withdrawals is basically how much someone drank or are drinking, how long they've been drinking for, how old they are, and if they have any pre-existing medical problems. So the doctor's going to ask about the alcohol use history. It's important that the person going through the detox is honest about it so they can manage the detox properly. The next thing is a history of any medical problems. If they have any history of heart disease, diabetes, liver problems. Have they been through detox before? And if they have, what was that experience like? Were there any problems or issues that came up during that time? The withdrawal process is not just physical, it's psychological and emotional. And without supports, the likelihood of someone succeeding is very poor. The medication is only managing the physical withdrawal symptoms and preventing things like seizures and keeping someone safe physically.